Very good morning to everyone. Uh, what we intend to do in the next uh, 30 40 minutes is to briefly talk about pediatric allergies. And we understand that, pediatric allergy is not just asthma or rhinitis. There's something known as an atopic march, which starts from atopic eczema, food allergies, which can later develop on asthma and rhinitis. And many of these conditions would be overlapping, and in one children you can see multiple of these manifestations. So, what do we intend to do, right? So we usually in our OPDs are managing asthma and rhinitis, and that is the main thing which we look at. But these patients or these children, they have a lot of burden of the other allergies as well, which includes atopic dermatitis, which includes allergic conjunctivitis and food allergies. So the question is, who manages them? For an atopic dermatitis, we tend to refer to dermatologists. For allergic conjunctivitis, to ophthalmologist. For food allergies, to allergist. But finally, at the end of the day, it is one patient. So what we are trying to say is that we need to somewhat learn the holistic management of an allergic child. So as a pediatrician, you should be comfortable in diagnosing and managing at least the milder varieties of these comorbid conditions, right? So the identification and at least the mild varieties you should be able to handle comfortably. And if we do that, then obviously the satisfaction of the patient, the family improves, the child improves as a whole, and it helps your practice as well. And we should also realize that at what point of time you need to involve a specialist, and that patient can be managed as a joint care. So, for today's panel, we will not talk about asthma and rhinitis because that has been discussed in most forums. We'll try and focus upon these three parts of allergy problems in children. With this aim, which I learned a few years back when I was at London for some pediatric allergy training, that we aren't managing these allergies in a holistic manner. So let's start with ocular allergies, and we understand that eye is widely exposed to airborne allergens, and the eye might independently react to the allergens. And believe me, if you start looking at the eye and if you start asking about symptoms of allergic conjunctivitis, there are lots and lots of patients who are there. They just don't complain because they think that you may not be the right person to whom these symptoms need to be reported, and it is usually associated with these things, and it has a significant impact on the quality of life and can end up into complications. So let's start here with our panelists. So Dr. Himshika, what are the usual ocular manifestations of atopic dermatitis? So not just conjunctivitis, but what are the in general ocular manifestations which you see in children?
Yes. So usually atopic dermatitis patient would present with watering for the eyes. Discharge would mostly be mucoid, redness, congestion, chemosis, and in atopic dermatitis per se, lid manifestations are more. So lid eczema, blepharitis, these conditions would be more. They'd be chronically rubbing their eyes. So you'd see lid folds, you'd see bluish discoloration of the lids. These conditions would be more common. And the conjunctivitis related to atopic dermatitis is more prone to having complications. Severe corneal complications like scarring, neovascularization, symblepharon. So they may more commonly present with decreased vision as well. So managing such patients.
Okay, so involvement of conjunctiva, involvement of skin, right? So they can have involvement of skin of the eyelids, uh, involvement of hairs are always can also
There
be
can be bad
there.
also.
Okay, so the next thing is a very simple question, and which a pediatrician would ask, that a child presents with a red eye. So in that situation, how do you make out that this is a bacterial conjunctivitis or this is an allergic conjunctivitis or some other reason? So what are the pointers which tells you that this eye looks to be an allergic eye?
Again, history is very important.
Okay.
So basically, a bilateral involvement. The child is chronically rubbing his eyes. There is watery discharge. There is mucoid discharge. Then there is seasonal variation that
Okay.
is increasing during the summer, spring months. Then there are some exacerbations. It settles down and again exacerbates. In bacterial conjunctivitis, you'd more commonly find matting of lashes, a purulent discharge. And while viral conjunctivitis, again, a mucoid discharge be more common, and the patient may also have lymphadenopathy, which would again indicate towards an infective rather than allergic conjunctivitis.
Okay, so a chronic course, relapsing course, intermittent
Bilateral.
exacerbations, bilateral involvement, a watery eye, and I think a very important feature is an itchy eye,
Itchy.
right? So what we understand is that if there is no itch, it's unlikely to be an allergic conjunctivitis, right? Am I right?
Yes.
Okay. So these are the manifestations which we usually see as Dr. Hemshika has talked about. So look for these features, and I think it is the most important is clinical, right? So there is no real investigations into it. It is mainly a clinical diagnosis which you are looking at. Okay, so bilateral involvement, presence of itch, which is very important. Again, clear discharge, burning. So these are the cardinal features, and in addition, you are also looking at other comorbid conditions. So if a child has significant rhinitis associated, asthma associated, dermatitis associated, and if it's a chronic relapsing course, then you are more confident that this is possibly an allergic conjunctivitis. Okay. So now, can you help us understand that what would you expect to find in an allergic eye when you examine it? First, from a pediatrician's perspective, who just does a basic naked eye examination, and then you can possibly help us understand that what you'll be looking at as an ophthalmologist.
So on a basic pen torchlight examination, we'd see congestion. So there'd be mild congestion, diffuse conjunctival congestion. There might be chemosis, especially near the medial caruncle. So the swelling, conjunctival swelling is usually more marked in allergic cases. Then there'd be a watery discharge again, and in more severe cases, especially in BKC, you might find limbal thickening, limbitis. So there'd be a whitish ring like thing seen on the limbus on pen torch. If you pull the lower lid down, then you might see congestion in the lower palpebral conjunctiva. You might even see papillae that are big enough to be seen with naked eye examination. So I think on a pen torch, everyone can make these things out. And per se, we would like to do a slit lamp examination. Here, we'd like to invert the lid, and we might see papillae. Again, in VKC, we might see Horner Tranta spots seen at the limbus. These are eosinophilic deposits. We might see on the cornea, we might see ulcers, punctate epithelial erosions might be there, shield ulcers, which may be due to the chronic rubbing of the papillae on the cornea and could be pursued due to the inflammatory process only. So these need to be managed very vigilantly because again these can get infected further and then lead to more severe complications.
So you have findings on the conjunctiva, okay, and you have findings on the cornea, right? So on the conjunctiva, you are looking at conjunctival congestion, redness. That is something which you can see. Can you see papillae with the naked eye?
If they're big enough, yes, you can see macropapillae. Some patient may have a cobblestone appearance of the conjunctiva. Then, yes, even the finer ones we cannot, but otherwise.
Okay, so if they're large papillae, then we might be able to appreciate those papillae, I think, especially on the upper lid.
Upper lid, yes.
Okay, so that is something which we could see. So, as a pediatrician, what suggests that this child is developing involvement of the cornea?
So, okay, pain, photophobia, blurred vision. These three symptoms would indicate that cornea is being involved. Usually, these patients have itching, stinging, burning, but pain is relatively uncommon unless there is corneal involvement. Intense photophobia, the child is not even opening his eyes in the ambient light. That again indicates that cornea will be getting involved, and blurred vision. So these three symptoms, and again on the torchlight examination, if we see a corneal opacity,
okay,
we might think corneal vascularization, opacity, infiltrates, anything, there will be a corneal involvement.
Okay. So we have talked about a naked eye examination and a slit lamp examination, which obviously falls into the domain of an ophthalmologist. I think you can help us, all the pediatricians here, understand these images. So what you find here is what we were talking about, like papillae on the upper lid. So how important is the examination of the upper lid?
Actually, it is very important because some of these children might have giant papillae, and then
Okay.
they develop a chronic condition where the papillae are rubbing the cornea, and there the non-healing ulcers might develop. And again, would help to differentiate between an allergic and infective conjunctivitis as well, because papillae are more commonly allergic forms.
So I think that is one learning point here, that just looking at the lower eyelid may not suffice. Learning to look at the upper eyelid, even with a pen torch examination, is something which we can learn, and that can help us to identify, whether they have signs of allergy which are there or not, and what's the severity. Because if you find really a cobblestone appearance or giant papillae there, then it means that it is possibly an advanced thing. Can you help us understand the lower images, what they look like? So
in the first image, we see whitish deposits or spots near the limbus. These are the Horner Trantas spots, more commonly seen in vernal keratoconjunctivitis. So these are basically eosinophilic deposits and epithelial debris that collects near the limbus, and again indicates a severe form of BKC. In the second image, we see a conjunctival pigmentation due to chronic rubbing and because of recurrent episodes of allergic conjunctivitis, the patient may develop pigmentation. And many patients give the appearance of a muddy sclera. Like these patients would, the eyes are very dull looking, the luster is less, and the sclera looks very muddy in appearance because of chronic rubbing. And again, then they develop xerosis, lichenification. So, not lichenification, but conjunctival xerosis. So, there's a loss of luster and pigmentation. And in the third image, we see superficial punctate keratitis. So we have stained this with fluorescent, and in a blue filter, we examine these. So these are like microcorneal erosion, epithelial erosions, which take up fluorescein staining. Again, a chronic inflammatory process leads to the development of these SPQs.
So the first two are naked eye images, right? And you can remember these images, because if you find any of these, then it means that it is possibly going into an advanced stage. Okay, so these are giant papillae which you might see on the upper lid, right? And hence we understand that looking at the upper lid is important. And so on the cornea, what do you find, ma'am, on the cornea?
In the right eye, if we see the upper half of the limbus, so it is more whitish. This basically indicates limbal thickening. So again, there is inflammation and swelling near the limbus. There is limbitis. And in the left eye, we see a corneal opacity, a whitish opacity on the cornea. So this could be an ongoing ulcer or a healed ulcer which has left a corneal opacity. Can be either.
So again, signs of corneal involvement can be there even on the pen torch. So we may not be able to, pinpoint that this is a shield ulcer or this is a punctate keratitis, but there are some signs of involvement of the cornea which needs a detailed examination. So these are signs of severity which we have talked about. If you find any of these in your examination finding, do refer them to an ophthalmologist. So these are the usual forms of allergic conjunctivitis you would see. A seasonal one, a perennial one. So usually they will have symptoms as we have talked about. They're IgE mediated. The conjunctiva shows follicles and papillae. The limbus is normal and the cornea appears to be normal on the examination. What we are worried more is about the VKC variety, which actually has a lot of complications which we have talked about in the past few slides. Okay, so if you have an uncomplicated thing which presents to you in the OPD or presents to your pediatrician, and we understand that the milder variety is more common, but obviously you have some patients who would get complicated and gets referred to you. So that's your domain. But can you tell us a basic management of an allergic conjunctivitis which a pediatrician can do?
So in milder cases, just some lifestyle modifications. We can tell them that whenever they come home from school, they should wash their hands, wash their face, wash their eyes. Then, because these allergens are very common. They might be dust, pollen. Excluding these allergens from their life would be difficult. So what they can do in day to day is maintain hygiene, frequent washing, changing pillow covers, bed covers, vacuuming carpets, and then lubricating eye drops, which may dilute the allergen and decrease symptoms. But most of these patients do require topical medications and do very well on them. So for first line, we usually manage them with dual acting agents,
Okay.
which are antihistaminics and mast cell stabilizers. So we try like olopatadine or levostatin. We try to give these, and if the patient resolves with these only within 2 weeks, then we continue them, and then we can stop and see if the patient require these medicines on a continuous basis or not, and then we can shift to other modalities.
So we need at least one ocular lubricating agent which
Yes.
needs to be used. So
Preferably a non-preservative agent.
Okay, and that helps in reducing the itch, and I think it is the itch which damages the eye because the constant rubbing is something which damages, as happens in atopic dermatitis as well. So an ocular lubricating agent is a must, right? And second is the first line thing which someone can use is to use a dual action agent. The most commonly available is olopatadine and bipotastine and caftidine. These are some things which are available. Okay, so this is the usual way it follows. Uh, so the dual action agents, I think, are the forefront of managing at least the mild to moderate cases and occasionally with topical corticosteroids. Okay, and this is the follow-up of their case. Gradually the child became better. You can see the papillae reducing in size, the cornea becoming clear. And this is the right and this is the left eye, and you can see the change which has been happening. At the end, we have talked about the usual manifestation. We have talked about how you pick up these manifestations in the OPD. We have also talked about some signs on naked eye examination, which helps you understand that it is possibly going into a severe disease, which refers to an ophthalmologist. We have talked about some basic management. So, just one word from Dr. Ritika on what is the involvement of an allergy specialist in these situations.
So, as sir already mentioned that
treating allergies is not just one single organ. We have to treat it in a whole. We have to keep a holistic approach to it. So many a times, children with just eye manifestations may not only have eye manifestation and have underlying asthma as well, and vice versa is also true. So if we are managing a patient with respiratory allergies, we must look at the eye and diagnose and treat VKC. And if an ophthalmologist is treating a patient with VKC, they must look at the other conditions and send to an allergy specialist for a holistic treatment. Another importance is allergy testing. When we have a patient of VKC with perennial symptoms, with severe eye disease, then allergy testing can help, because if we find a perennial allergen like house dust mite, we can offer them immunotherapy and other treatment options, which definitely improve the outcome. In fact, we have few patients in our team where we are treating house dust mite sensitized VKC patients with immunotherapy, and this particular image that was shown in this presentation is one of those patients who was started on VKC along with the topical treatment, and we were addressing the respiratory allergies in this patient as well, and the quality of life definitely improves. So that's the role of an allergy specialist.
Yeah, so I think immunotherapy to dust mites, especially for a recalcitrant rhinoconjunctivitis, has class 1 data. So before moving on to the next one, atopic dermatitis, our chairperson, sir, do you have any comments on this? Would you add on something to what we have talked
I
about?
think clinically managing our allergic conjunctivitis in our routine practice, we see a lot of conjunctival fluorosis. I think that is the earliest feature redness and phimosis. I think most of them we are picking up at that stage, and probably early mild cases are treated much faster. The second point I would like to mention here was about the your immunotherapy and all those things. Has immunotherapy come that way, or it is just for specific allergic conditions where your immunotherapy is working? Because most of the times our clinical history and our treatments are good enough to manage allergies.
Yeah. So there are situations, and we have got into that situations quite frequently in the OPDs, because possibly it's a referral bias. That children present with rhinitis, which is not just getting better with intranasal corticosteroids, montelukast, and oral antihistamine, and their quality of life is quite bad, and they have associated conjunctivitis as well, which is equally difficult to treat. These are perennial symptoms; they are lasting for years, and the response to pharmacotherapy is inadequate. In this situation, if this satisfies all these criteria, so being a long-lasting disease, being present throughout the year, being on maximum pharmacotherapy and affecting significantly the quality of life. If all these criteria are satisfied and it is a proven dust mite allergy, then in this situation, given immunotherapy has good amount of data to improve medication scores, symptom scores, quality of life, and long-term remission.
I think last point definitely I would like to mention the pediatrician as well as the allergy specialist. They should work in tandem, because ultimately these patients will be followed up by the general pediatrician. So a good coordination definitely would go a long.
Absolutely, sir. Totally agree. That is the key message which we are trying to say. So let's look at the skin now, right? So again, as I said, you should be able to uh, identify atopic dermatitis. So a few years back, if a mother told me that my child is having itchy skin or some rashes, I said, ठीक है आप dermatologist को दिखा लेना. We are not very confident in looking at the skin, but that's not the way it should be. You should be able to identify, and again, you should be able to manage at least the mild cases. So the primary thing is the itch, or primary thing is the rash, is an enigma which we have been talking about. So most people believe it is the itch which rashes, and it starts with the itching, and that is what leads to a skin damage. So just briefly, Dr. Tanvi, can you help us understand how this cycle goes on?
So atopic dermatitis is basically an amalgamation of environmental factors, genetic predisposition, and as well as dysregulation in the immune system. So that's how it basically functions. So if there is a family history of atopy in the parent or grandparents or siblings, there is a chance of a child to have a 10% chance of a child to have atopic dermatitis. So that is one, so which is the genetic predisposition. Otherwise, environmental allergens, yes. So the most commonest is dust and dust mite, which we have seen as an allergic specialist. You have also seen these are the most commonest in India as well as abroad also, which is one of the most common environmental allergens which the child can manifest as an atopic dermatitis.
Okay. So, uh, how do you understand that this child who presents to us has atopic dermatitis? हमें तो सारे एक जैसे ही लगते हैं skin lesion.
So the acute lesions in an atopic child, and especially an infant, is mainly the involvement of the extensor aspects. The facial dermatitis, the extensor aspects.
So the distribution of lesions.
Distribution of lesions.
Okay.
So in infants it's mainly extensor, whereas as they grow old, toddlers and all will be more flexural. And then how the lesion presents. The acute atopic dermatitis is more oozy lesion. There will be vesiculations, there can be bulla formation and extreme itching. Itching is, like we all discussed, that it is the most important cause. So acute, chronic as it becomes more lichenified. The lesions become more hardened. They become more thickened and leathery appearance, especially in a adolescent atopic dermatitis.
Okay, so I think the distribution of lesions, the age of presentation, the symmetry of presentation, the chronic relapsing course, presence of other comorbid allergies,
Associated
food allergies, rhinitis, might be having some asthma later. These are some clinical features which help us to understand that this child actually has an atopic dermatitis, and again it is a clinical thing. And this is the distribution which Dr. Tanvi has been talking about. So on this side you see extensor involvement classically in infants, and as children grow older you will realize कि उसके skin folds में होगा, यहाँ होगा popliteal fossa पे होगा, neck पे होगा, sometimes on the face and sometimes hand eczema. So that's the classical thing which you see. But if you look at severe cases, then they can have bad eczema throughout the skin. So any diagnostic criteria which pediatricians should remember?
Atopic is mainly diagnosed clinically. So there is no blood test as such. IgE is one, but 80% of people can have positive IG or high IG. 20% children don't show high IG. So as such, there is no diagnostic criteria in the form of lab investigations or anything.
Clinical diagnostic criteria?
Clinically, like we discussed, so itching is one most important. So the one thing which I wanted to tell everybody is the seborrheic dermatitis and atopic, we see similar age group. So seborrheic dermatitis is not itchy at all. So if you ask the parent if the child is scratching, so they will also present with facial features, they will present with chest and neck involvement, but that child will not be itchy. And the distribution could be slightly earlier, like 3 or 4, 2.5 to 3 months of age. Normally atopic children comes around 4.5, 5 months, 6 months of age. Very itchy, not controllable, cranky. But seborrheic children, except the look of the child, they are not least bothered. So what is happening to them?
Okay, so that's an important thing.
Yes.
Okay, so presence of pruritus. Without a pruritus, atopic eczema doesn't happen. That's the primary thing. A typical morphology of lesion, age-specific pattern, the chronic and relapsing history, early age of onset, other atopies is something which you are looking at. Okay, so just mild atopic dermatitis which presents to a lot of people. How do you manage that? Some basic insight in 2 minutes for everyone.
Moisturize. So this is the key to atopic dermatitis because there is lack of moisturizing substances in the body. So the most important thing you have to tell the parent or the caregiver is to moisturize the child. The more we moisturize, whether it's a normal regular oil like a coconut oil or any high branded moisturizers, but we have to moisturize the child. So that is the key important. We forget, we start giving steroid, we start giving tacrolimus or pimecrolimus, but we forget the moisturization.
So I think moisturize regularly,
Yes.
moisturize all over the body.
Yes.
Moisturize immediately after bath within 2 to 3 minutes, which is known as a soak and seal.
Is there any technique?
So that's called the soak and seal technique. So you don't dry the skin, you just pat dry. Try and use a Syndet or a neutral pH soap or a body wash. Apply a layer of moisturizer just in one stroke. Don't rub it, okay? And leave it till it absorbs.
So rubbing sometimes can precipitate itching. So if the parent keeps rubbing the moisturizer, that also can precipitate itching, so that can worsen. So like what Dr. Ankit said, that yeah, in one direction we just apply it and just leave the child.
Use of topical corticosteroids, low potency, and sometimes using calcineurin inhibitors. So, tacrolimus, if you just do 2 or 3 things, then most of your patients can be managed.
Sir, actually, the tacrolimus is not, if you say it's not FDA approved for children less than 2 years, actually 12 years of age. 0.3 is for more than 2 years of age. 0.03. 0.1 is for more than 12 years.
Okay, so
Off-labelly, we have been
for the mild variety, occasional use of a low potency corticosteroid
cortisone 1%
on the
sometimes
face.
on the face, and we can go up to a fluticasone cream, which is second to third degree. So in the class categories of steroids, 2 and 3. So we can reach up to 3.
Okay,
More
so
than
we
3.
just remember 2, hydrocortisone and fluticasone for the mild to moderate cases. Occasionally good moisturization, and we leave things like dupilumab, systemic immunosuppression, and JAK inhibitors for.
Crisaborole is a new molecule which has been for children less than 3 months of age.
Okay,
So that
but
can
even
be-
crisaborole is for the mild to moderate variety. For the severe one, using more of JAK inhibitors and dupilumab. Okay. So again, the role of an allergy specialist again here is to look at comorbid conditions, diagnose them, help with allergy testing, and there are some situations when uh, doing immunotherapy can be helpful if there are multiple allergies. Okay, so briefly we will go on to Dr. Ritika, who will help us understand food allergies. So very few questions. What are the common food allergies you see in India? So we have actually burned out of time. We are asked to vacate the stage, but we aren't. We are a bit resistant.
The big 8 food allergens that we see in the Western world are there in India also, but we see less of food allergy in India. We see more the peanut allergy is almost 1/10 of what we see in the Western world. But yeah, allergy to milk, wheat, these are some of the allergens which are seen in India as well. Peanut allergy, nut allergy, not so much.
Okay, and why do you think why peanut allergy is so common in the Western world, and how many can छोड़ दिया?
So in allergies, it's a genetics also plays a huge part. Environment plays a huge part. Your cultural practices also play a huge part. One of the hypotheses is that early introduction of peanuts in our children, like our age-old Indian practices are massaging the children with groundnut oil. Our food is cooked in groundnut oil, so the child is exposed to the nut protein very early on in age. That can be one of the reasons why we don't have so much of peanut allergy, and then of course genetics and racial differences are there.
So I think we see a lot of kids, NRIs who migrate to US, Canada, and Europe, and the amount of food allergies they get is almost similar to the Caucasian population, and it is more related to the food habits than per se to genetics. And we are still saved from very bad multiple food allergies, what is seen in the Western world. So these are some clinical manifestations of food allergies. Urticaria, angioedema, sometimes dermatitis, vomiting, colic, abdominal pain, acute respiratory manifestations, and sometimes anaphylaxis. So briefly, Dr. Ritika, how do you diagnose that this child has a food allergy?
So first and foremost in food allergy, history is the most important thing. If a parent has noticed that a child eats some particular food item and has an immediate reaction to it, then that is clear cut that that food allergen is the culprit for causing those reactions. By reactions, I mean a child has a skin rash, IgE mediated reactions, immediate severe abdominal pain and vomiting, skin rash, maybe angioedema or anaphylaxis. These are clear-cut indications that the food allergen is responsible. However, to confirm it, we do a oral food challenge test. Of course, in office practice, under all precautions, that can be done. Usually, practice OFC is not required because the history is quite confirmatory. Another thing is elimination and then reintroduction of the food item in the diet. So, especially when it comes to cow's milk protein allergy, we eliminate the food item from the diet of the patient and we document, we see whether there is an improvement in the symptoms of the patient or not. And once the child is completely improved, we can give him some milk and then see whether the symptoms have come back again or not. And this is done over a period of 4 to 6 weeks. That is another way of going about it. But elimination diet and reintroduction is a more safer way of confirming more indolent
IgE mediated food allergies, you can do either a skin prick test or a serum specific IgE. But remember that for any food allergy, don't do a non-selective panel. You can get a lot of false positives, which are just minor sensitizations and they are not clinically meaningful allergies. So don't order a panel. Choose a specific food. So if the child is allergic to milk, do it only to milk. If the child is allergic to one nut, do that nut and the rest of the nuts to understand what other nuts can be given. So long-term management involves elimination, diet, education. We will not talk about specific immunotherapy and anti-IgE, but there are a lot of challenges and cofactors which are associated. My teacher and mentor to please be here and give his comments on this topic on which he is a real expert.
Could you go back to that slide on multi-system symptoms?
Okay, I think we are running short of time.
Yes.
We'll take the questions and queries over the tea break. So we need to wind up.
I think
Dr. Vinder's comments are most welcome. You can join us for the felicitation of the chairpersons. And other please.
It has been adequately covered. What is important is just as sensitization is important for us.
Okay, so we need a mic.
Sensitization about the topic is important for the baby. That's where I think it.
I will request you to felicitate all these speakers.
I would just like to mention one more point. We, in our practice, see a lot of allergic boys. So I think the first year of life, the first few weeks of life, we start massaging with 1